I'm Dr. Castells, for the ones of you who don't know me, and this is Dr. Alvarez-Tos, and I think Dr.
Excuse me, I'm sorry, I didn't mean to cut you off. These microphones, they're trying to record each session individually, so each set of tables has a mic. No, it's not through the PA, but this is just recording so that they can hear. So as people speak, if you can kind of pass it around so it can be recorded, I appreciate it. Thank you.
Very good. So again, I don't know. Is it recording? Maybe it's recording. Doesn't matter. I'll speak to this. So, and again, there's just, I believe the two of us, Dr. Alvarez-Tos and myself, Dr. Aiken, and Dr. Remind Afrin. And Dr. Aiken, I believe, was supposed to be here too, or? I think he's in the aggressive. He in the aggressive, okay. So there's the three of us who can answer the question. So please, I'm just going to pass this on and then you can.
I have a question. I was diagnosed at least 12, maybe 13 years.
She said to speak.
It's just for recording.
Yeah, it's picking it up. At least 12, 13 years ago by a doctor at Mount Sinai who is a carcinoid cancer specialist. And he was able to differentiate the difference between carcinoid and the mastocytosis, and so he diagnosed me as mastocytosis. At that time, I don't think there was such a thing as MCAD.
Mast Cell Activation Syndrome, yes.
And so the question I have is, should I be going back through this process to see if maybe I have mastocytosis truly, or if I have MCAD? I am on medication and it is working reasonably well, but I do need to. I've had 2 episodes even in August within 2 weeks, so maybe I should. I don't know.
So we can answer. Mast Cell Activation Syndrome is a diagnosis of exclusion. So if you already have a diagnosis of systemic mastocytosis, you should stay with that diagnosis. And the treatment of that, and the symptoms of that can include anaphylactic-like events, and they can be treated, but you should not seek another further diagnosis.
But it didn't include. I do not have mast cells in my bone marrow.
So he made the diagnosis of mastocytosis without mast cells in the bone marrow.
I don't know if that criteria was available there.
So I guess you could actually be reevaluated for mastocytosis and then decide if this is truly a mastocytosis or mast cell activation syndrome. Okay. Yeah. So those could be reviewed. Yeah, definitely.
Well, I guess my question was going to probably go along the same lines. I was diagnosed at Stanford in 1996 before the WHO criteria, and they did the diagnosis via 3 different organ biopsies. Do you think they still have the slides there? Would it be something that you could look at that point in time and say if they had spindles or if they were, high number? It was extremely high numbers what they said, but they never told me how high, and they did tell me I had systemic mastocytosis. They did a methylhistamine and a whole bunch of other tests, but I never had a bone marrow biopsy. I haven't really felt the need to go and get one unless, of course, I want to go in a trial or whatever. But I often wonder if some of the other symptoms I'm having as I'm getting older are just getting older symptoms, or maybe my mastro is getting worse, and maybe I should go through that. So.
As to whether the center where you obtained your biopsies still has those slides on file,
15 years ago.
Who knows? I can tell you that I believe that the practice at most academic centers anyway is to retain slides for a very long time. I think my personal record presently is going back to slides from 16 years earlier and having them reevaluated and finding that a mast cell disorder had been missed. So I think you just have to call the pathology department and ask what they have on file. As to whether increasing symptoms over time are aging, versus escalation of symptoms of a mast cell disorder. I think the only possible answer is yes. That is, it could easily be both. And I think you'd have to go into a lot more detail as to the specific symptoms that you're having to have a better chance at distinguishing. Not necessarily. I think it may simply be worth having your symptoms, just to start with anyway, having your symptoms reviewed in more detail to try to decide whether these are symptoms that are more consistent with mast cell activation or symptoms that are more consistent with just aging. I think it's just an issue of the particular specifics in your case.
In addition to that,
yeah, it's just recording. There's no amplification.
In addition to that, I think it's an important point that if we can review the sample of the bone marrow, we can only explore if you have mast cell clusters. But in our experience, patients who actually have mastocytosis without skin lesions, 40% of them don't have mast cell clusters. So I think the most sensitive method is to analyze the immunophenotype of mast cells. So if you want to know if you have mastocytosis, I think only reviewing the sample made 16 years before, I think is not enough. But I think also that is more important to review the symptoms before.
Oh, I had a question for her. Oh, well. All right. Well, maybe you can help me. I was diagnosed last February with Mast Cell Activation Disorder, and this summer I got Lyme disease, and I was doing fairly well until I got the Lyme disease, and I was deathly ill with fever of 105, and I'm not coming back from that, and I don't know if I don't know. It just seems, would Lyme disease have that big of effect on the mast cell? I know it's bizarre.
I think it's difficult to know because we have no cases having both diseases. But
I also have autoimmune disease. I have
both are unrelated diseases. There is no relationship between mastocytosis and other autoimmune diseases, and it's true that autoimmune diseases can cause clinical symptoms which can be significant. So.
Well, she's back. All right.
So we are the best group.
Yikes. Should I asked my question, but it was for you and the other doctor. Should I ask you now?
Yeah, of course. Let me 1 second.
Okay.
We can actually be a little bit further here so we can. Right there.
So my question was, I'm seeing Dr. Greenberger for Masto for GI. I have a lot of GI symptoms,
Yes.
but I also have a very high ANA.
Okay.
And I'm wondering if I should also be seeing you as part of, because there's so many other symptoms that the gastro isn't
Going to be addressing.
right.
Yes, so Dr. Aiken or myself.
Okay,
definitely.
so I think I just call you and say I've been here and
Yes, the office, and well, actually,
referral from your doctor because that's
Okay.
what Massachusetts requires.
Okay.
And then we'll obviously case and
Okay, and I was on Plaquenil.
That's good.
But I think it reacted to the masto. Would that do that?
Not necessarily.
Really?
No.
Okay.
We're going to try to shout. So the question was that she had an elevated ANA and then gastrointestinal symptoms because she was on Plaquenil. Would the Plaquenil have any impact on the mast cells? We don't have any data to support that the Plaquenil does any activation of the mast cells, so it wouldn't be detrimental.
Okay.
I'm sorry, what's Plaquenil?
Hydroxychloroquine, so that's a treatment that's used it's an anti-malarial medication, and it's used for Sjogren's, rheumatoid arthritis, and autoimmune diseases in general.
Does it have quinine in it?
No, it's not.
Okay.
Next one. Yeah.
My question really is for all of the doctors. I was diagnosed with mast cell activation in 2008. I've been on several H1 and H2 inhibitors and gastrochrome and catodafin for 2 years. And I have seen a decrease, although not a total elimination, in the classic anaphylactic symptoms. But it's a whole lot less than it was. My question is, the thing that's really come up in the last year and seems to be increasing is that I'm having hypertensive episodes with wheezing. I have the typical feeling of doom that you have a lot of times with the low blood pressure and the classic anaphylactic symptoms, but it really, when I hit the emergency room, my blood pressure is over 200, typically like 200 over 110. I'm wheezing to the point they think I'm having an asthma attack. But the typical treatment for anaphylaxis, the Pepsids, the steroids, does stop the episodes. And I'm just wondering if the other doctors have seen that with patients in their practice.
Actually have some patients with increased blood pressure levels instead low blood pressure levels, but it's not very frequent, and we think is due to the release of mediators that can activate this kind of process, and the treatment, I think, is the same. It's corticosteroids and antihistamines. It's quite good. And sometimes we recommend to use antihypertensive drugs for the acute episodes.
I was wondering if you could talk, I've been struggling with kind of the chronic, more day-to-day symptoms of fatigue and dizziness and light sort of brain fog, and I was wondering if you could talk a little bit about possible causes. I haven't really gotten a clear answer on like what part of the mediators would cause that and any kind of treatment ideas.
But this is in the setting of any kind of diagnosis or no diagnosis?
No, I have a diagnosis of Mast Cell Activation Syndrome. I don't have mastocytosis.
And what was the diagnosis based on?
Elevated tryptase and elevated histamine.
So your bone marrow biopsy was negative?
That's right.
Okay. So essentially, if you had elevated tryptase and elevated histamine, the mast cells had part of the release, so you had mediators released. Right. And so other mediators that I presented the day of my talk were cytokines, such as what we call TNF-alpha, tumor necrosis factor alpha, and this is some mediator that is released also in cancer patients and some other patients with allergies, common allergies, that can actually include fatigue. Another one would be interleukin-1 beta that also can induce not only fatigue but also some fever and some like inflammation-like type symptoms. So although those cannot be measured in the blood because there is no standard kit to measure that's FDA approved, that is associated with the release of histamine and tryptase. So this is possibly the symptoms. The only thing that would actually get the mast cell not to release would be something like sodium cromolyn. Yeah. So the recommendation would be that you start with sodium cromolyn, the gastrochrome type medication, and then increasing the dose.
I already tried the 1 ampule 4 times a day, so I guess the next step is to just keep trying
to increase that, and then to rule out any other cause of being like fatigue. For example, you're a young woman, possibly TSH, hypothyroidism is associated with that, and something else called Hashimoto disease, which is autoimmune thyroidism, hypothyroidism can be associated. So eliminating that, anemia is another cause for that. So you have to eliminate all the other potential.
So they come back to this. So the question is just treatment.
And then if you have histamine and other mediators, blocking those mediators would be important with, like, say, anti-H1, anti-H2 mediators.
I'm sorry to introduce. We need to move in a little bit more over there because this is the elevator.
Okay. So how far do you want us to do? Is it good here?
That should be. How long is going to be answered?
Excuse me?
For how long is going to be?
Less than an hour. It's like 40 minutes, I think.
Because even like this round is going to be set up.
Sure. So to ask Dr. Valerie Slee is the organizer. She told us.
Like how this group like making like this side like the L, like the people can move it like that. It's perfect for you.
Wow.
I don't know what we want to do.
What she wants to do.
Like this.
Like this. Yeah.
Okay.
Okay.
We're staying right here.
Okay, great.
Okay, I'm a little bit confused because yesterday, I'm not sure which doctor, but he said if you have hypertension, you're not supposed to use an EpiPen. Well, I was told I have hypertension. So do I use it or not? Not that I have.
I do not recommend. I'm going to start and then the others can. I do not recommend when you have hypertension to use an EpiPen at all whatsoever, because you actually can produce, the constriction of your arteries. You can actually have a stroke. I don't think it's recording. Flatly, measure your blood pressure and you have hypertension.
Oh, they'll tell me?
They will tell you.
Oh, okay.
You're not supposed to know if you have hypertension unless you have something to measure at home.
Right.
If you have it, then that's fine. But if they measure it and it's over 140 for systolic blood pressure, you should not use an EpiPen. EpiPen is reserved for hypotension. Cardiovascular, that's what the EpiPen. Pressure is really high, they should use steroids, they should use antihistamines, but they should every day, same dose at that time.
Hey, this may sound like a dumb question, but I was diagnosed like 4 years ago with Mast Cell Activation Disorder. I've had unbelievably complicated medical issues, as Dr. Castells knows. But I'm just really talking to people. This is my first conference. It's amazing to me how many other people besides me have a lot of either neuromuscular conditions, neurological conditions. I wonder if there's research being done about that, if the doctors see the correlation with that. I mean, I'm 45. I work full-time almost right now, trying hard to hold on to it. But in between major episodes, I do okay. But when I have a major episode, I don't get sick. I get really, really, really god-awful sick. But I have like all these crazy rare things. And talking to other people that are here, I'm not the only one with all crazy rare things. So I just wonder if there is research being done. I mean, just based on the conference, I can't imagine. I see that I'm not the only person, but I wonder what the doctors see from your standpoint. I don't know who.
I see this in I see neurologic issues and neuropsychiatric issues in many of my patients. I see neuropsychiatric issues in many of my patients as well, and I'm not aware of any currently ongoing trials looking at that issue either diagnostically or therapeutically. Are you aware of any trial?
More neuromuscular, not psychological, though. More like fibromyalgia, multiple sclerosis, those types of things.
There is some literature evolving that is looking at the presence, potential presence of mast cell disease in patients with fibromyalgia. There was an interesting paper that came out earlier this year that in a small number of patients, like 14 patients, looked at random skin biopsies in patients with fibromyalgia and found a significantly increased number of mast cells in the skin of fibromyalgia patients compared to normal control patients. But are there any major research studies going on in that area? I'm not aware of any.
I'm not aware either of major research studies with neuromuscular issues, but like you said, this is an observation. I think is listed in the list of syndromes and symptoms that we observe in patients with systemic mastocytosis. It's true that mast cells are located around the bone in the intramuscular junction, so there is a lot of research in an area that's a little bit different, rheumatoid arthritis. There's a lot of mast cells in the synovium. So the synovium is the area that the joint helps move. And in that area, in the last 5 years, and this was research done at Harvard, there's a lot of tryptase, there's a lot of chimeras, there's a lot of the mast cell proteases. So that it started a process of research in that arena using antihistamines to treat patients with rheumatoid arthritis. And it was not completely successful, but then they also used TNF-alpha blockers, as we all know, and TNF-alpha is also released by mast cells. So whether it's addressing one way or another, I think that it might not come from the mastocytosis, research center, but from other places like rheumatologists are working very actively at that. Do you have any of neuromuscular?
We can talk about general symptoms.
Right. I think Dr. Theoharides also was doing some kind of analysis of the patients with systemic mastocytosis and trying to associate that with any other neuromuscular disease associated. This is very different than what we call the mixed organic brain syndrome that I described in my talk, where patients get impairment, and it can be a lot of other things, but this is like more physical neuromuscular. And I think that Dr. Theoharides was looking at the interaction between mast cells and neuronal junction, even at the muscle layer. So I think it's important. So let's.
I had a question about, despite trying to get sort of even coverage with H1 and H2 blockers, I've noticed that in my case, I get sort of nocturnal flushing, where if I wake up at 3 in the morning and I look in the mirror, I am, purple. Is there any sort of thought that there is something to do with cortisol or hormone imbalances, or something that actually, it's not just breaking through the medications, that there's actually something else around the body rhythms that's causing that type of thing?
Sure, I'm sure that hormone system have a very important impact on mast cell activity, and the example is the increase of symptoms in women in the premenstrual cycle, and there are also papers on the impact of some hormones like CRH, I think, on the impact on an increase of symptoms, and this reflects that probably, the hormones have a cycle during the day, and probably in your case there are any hormone that increase in the night and release your mediators in this case. So I think so. It's a relationship.
Just to come, my husband always, except for 2 times, goes to the hospital between 1 a.m. and 3 a.m. constantly. But I had a question. If you have hypertension, are there certain drugs that you should not be taking?
Yeah, I mean, all medication that can raise blood pressure is medication that should be avoided. But in terms
Of mastocytosis.
Like steroids should not be completely recommended because they can raise your blood pressure. And so those are medications that we should try to avoid if the blood pressure is pretty high. They can actually further raise.
So if your throat closes up and you have hypertension, what do you take then?
We started with antihistamines.
Okay.
Antihistamines. Those would be recommended at the time. And then going along with that, the people can be treated with antihypertensive drugs at the time of those crises, and then maybe they can use steroids along with that. So if you are already in the emergency room, definitely clonidine or some other antihypertensive medications.
Yeah, Bill usually has very low and then it's very high by the time we get to the emergency room. So it's both ways. So, okay. Thank you.
I guess I have kind of a two-part question. One is, once people have been diagnosed with mast cell activation disorder and been starting to get treated for it, I mean, how long does it take generally to have people find a really good improvement? I mean, I find that I've certainly had improvement, but I think I started in July, but I'm hoping for more. I mean, I still have brain fog and other things going on, and then the second part would be, I'm not gainfully employed anymore because of the disease, and how many people are able to work with the mast cell activation disorder. So, anybody?
Yeah. My wife's not here, but she's out of, she's in another one right now, but she's out of work right now as well. And she's just started getting treated, probably diagnosed about a year ago. So we just got on Chroma, and so we'll see how that does.
Is she have mastocytosis or?
She has mast cell activation syndrome, and in one of the questions I was going to ask, and I think she'd like to be here to ask this, so she'll be here, but if there's any relation to the autonomic nervous system, because she also at the same time has POTS.
Oh.
Okay. So she just took POTS a lot, but yeah, she has the same thing, so she's hoping to get back, but she's not there yet.
See, I was working, I went out, I took a month vacation, and then I tried going back, and I went into shock for 4 days, and the day I woke up, I couldn't walk. It's hard for me to get back. So once you're working, don't go out, because you can't get back.
So I mean, if you look at the stats or how people usually do, I mean, how long does it usually take to kind of stabilize things, stabilize the mast cells, and get to a point that, or work with different medicines?
So I think it's very hard to answer your question, because what we call mast cell activation syndrome may be very different things. And as this has only surfaced in the last few years, and we have produced very recently criteria for the diagnosis, it's a little bit like the mastocytosis story. In 91, when the criteria was out, they talked about one type of mastocytosis, and then now we have aggressive, we have the one associated with hematological malignancies, we have the one that's associated with skin disease, the one that's associated with Hymenoptera. So there is like a variety of a very huge spectrum. And so everything in the same category we actually do right now, is so that patients in my to blockade and some others on remeasuring mediators. It's just like what Dr. Greenberger described, a mediator positive patient, where we are able to measure an elevated tryptase, an elevated histamine, an elevated possibly prostaglandins, and we remeasure that 6 months later or else. Then they can actually rebound. It is a tough place to be at that time. We do the best we can with the tools that we have. So. I don't know if you.
I know it's a wide spectrum of mast cell activation, but if you look at the whole spectrum, I mean, how...
I'm not aware of any statistics. Again, speaking solely from my own experience, I have many patients who continue to function and continue to work or go to school. And I also have many patients, I would say probably a minority of patients, maybe not a small minority, but a minority of patients who are significantly affected. Their activities of daily living, are significantly compromised. Can't go to school, can't work. I do spend a lot of time filling out disability forms and writing letters to disability commissioners.
I was on I was out on medical leave for 7 months 2 years ago. I did try to go back about 3 months in, and I couldn't do it. The stress in that position. I was out again in 3 weeks. So I was out 3 months for 3 months and then another 4 months. I was a product manager for a healthcare information system, but where I was very, very lucky was that my employer, when I decided that I was ready to come back to work, it was still a struggle, but I made the decision after I tried to come back and couldn't. But it was a highly stressful position. They worked with me to let me come back in a less stressful position, and I work 4 days a week. I don't work on Wednesday, which breaks up the week, and like I said, I'm very lucky that they were willing to work with me, but even when I came back, it was very hard. But I would say this summer I finally felt like I was functional again, which meant I was, I was pretty out of it for a couple of years. It was hard.
All right, thank you. Thank you very much.
You want to...
I hope it's okay to squeeze in a couple questions about the muscle involvement, or if there is any neuromuscular involvement. It seems like I read somewhere that tumor necrosis alpha messes with the mitochondria. Is that true? Have you seen that in practice?
Mitochondrial disease?
Yes, due to TNF alpha.
Dr. O'Hara, I think, is aware of that.
Mm-hmm. Okay.
The secretion of TNF alpha inducing mitochondrial disease.
Okay.
I'm not aware of that.
Okay.
Connection.
Yes. Okay. And then, do we see the c-KIT or the JAG2 or whatever mutations with the MCAS also, or is that only with systemic mastocytosis?
We need to have a negative KIT mutation to diagnose it's necessary to have a negative KIT mutation to diagnose MCAS. But there are some cases in which you can have a positive KIT mutation with no other criteria for systemic mastocytosis. So this is which we call clonal mast cell activation syndrome, but it's a very rare disease. And in fact, we don't know if it's a new disease or a subset of a kind of mastocytosis with other findings, you know. But if you have a negative KIT mutation, your disease will call mast cell activation disorder, you know.
Really quick. Or all three of us are dealing with this. We're all developing low ACTH and cortisol and DHEA levels. And I'm not sure if anybody knows if the mast cell activation disorder is causing that, or if it's somehow vice versa, or is it involved even? Do you have any feelings on that?
The mast cells should not cause low ACTH. We have at least the products of the mast cells should not induce like even the proteases. But again, as Dr. Albertosa was saying, maybe you need to typify if there is like a KIT mutation or some other associated syndrome with that, maybe because hypoaldosteronism, some other adrenal type of disease should be looked upon. Those are autoimmune diseases, so they could be autoantibodies against the adrenal gland or against parts of the adrenal gland.
I think we've been checked for just about every antibody test I can think of. That's why it was just left there sitting on the table and was wondering. It's kind of up in here.
Yeah, it's hard because, as we said, we don't have a lot of tools. If you don't have an elevated tryptase and you don't have a c-KIT mutation and your bone marrow is negative, it's hard to make the diagnosis. It's the diagnosis of exclusion. And again, the other aspect of the disease is treating you with anti-mediator therapy. So if there is a response to that, then that's what includes you in the mast cell activation syndrome category.
We had an incredibly positive response to H1 antagonists and chromosomes.
So that would probably put you at
almost
least 2 of the criteria. Yes. It might be, yeah.
Thank you.
I have a question about the leukotriene antagonist. What kinds of symptoms does that seem to be related to when you choose to do that, when you choose to?
Well, like we presented, again, patients who have swelling, patients who have the respiratory symptoms. Leukotrienes are involved in symptoms such as like asthma-like symptoms.
Right.
And then what we call angioedema-like symptoms. So those are kind of the 2 variants of things.
Now, I've just been having a lot of issues with windedness, and I've been told that my pulmonologist said that your, breathing is the same as it was 2 years ago, not to worry about all this, but it still comes, and it lasts for an hour or so, a tightness up here. And I asked him about leukotrienes because I'd heard about that, and he refuses to give it to me. He says, you don't need that, but he doesn't tell me why I don't need that. So I just wanted to find out. I wanted to know what that.
Yeah, you should be a good candidate.
Okay.
Doing a pulmonary function test would also be helpful. So
Yeah, well, you've got that now. So talk to you in about 3 weeks. Okay. Thank you.
You know within just a few weeks whether or not a certain drug works, but one of the complications I found that is that sometimes it's more the cocktail rather than one drug. So it's not that you can sort of introduce one, take it away, introduce another, take it away. It's somehow the synthesis of how they're all working together. Is that a common experience?
Thanks. Each patient appears relatively unique in my experience, and sometimes it is a synergy amongst multiple treatments that makes a difference. Sometimes not. And I think it still goes back to trying as much as you can. I'm hesitant to continue medications, particularly the more expensive ones, which ordinarily I'd expect a response within several weeks, and I see absolutely nothing, or even toxicity, I'm very hesitant to continue those medications in the hope that adding yet something else on will then create a synergistic response with the one that they don't seem to be responding to.
I just had a question. I'm newly diagnosed with mast cell activation disorder, but I know that you had mentioned, Dr. Castells, yesterday that a fever could be a symptom. It's not a common one, but when I started with symptoms, very long story, but I was sick with strep, and so I was monitoring my temperatures because I was having 102s and this and that, and they have not gone away in almost 2 years. I'm still having fevers. I didn't know if anyone else was ever experiencing this, because I've gone through a whole slew of doctors, and we've stopped looking for the fevers, and I started treatment with Dr. Greenberger for the mast cell, and then at the same time I got strep again. I have 2 kids, so it's in the house often, and it was within the 3 weeks of starting the H1, H2 blockers, and then I went on a week of antibiotics, and then I had the best 10 days of my life in a year and a half. It was not perfect, but it was a glimpse of what my normal life used to be. And then now it's progressively getting worse again. So the whole topic in my house is where I don't have any actual tryptase, I don't have any levels, I've never done a bone marrow, we kind of started treating me. Is this truly, can I say that this is from the mast cell, or is there something more going on that I've stopped looking for? Which I know is a hard question, but...
You were...
Next year. There you go.
Three comments. First of all, the disease certainly can produce fever. More commonly, my patients complain of chills, or actually most commonly, not specifically chills, but a sense of feeling cold virtually all the time. That's what I hear most commonly when it comes to temperature-related issues. But sometimes I hear about fever. A second comment: if you're getting frequent episodes of culture-proven strep throat, and if your physicians have not yet checked a quantitative IgG, immunoglobulin G level, you may want to have that checked, because in my experience, some patients with the mast cell syndrome, mast cell disease, and I can't tell you what the mechanism is, but some patients clearly do develop a what's called a humoral deficiency, a deficiency of antibodies that help protect against common infectants like strep. And for patients who have repeated major infections, sometimes a simple monthly infusion, a prophylactic infusion of antibody, something called gamma globulin, can help restore normal levels of protection against common infectants. So that's something else to look at. And I had a third thought, and I can't remember what it is.
Definitely echo Dr. Offren regarding the fever. Fever is not typically associated with mastocytosis or mast cell activation syndromes, and we have to exclude any other potential cause. The most common cause in adults of a chronic fever associated with infections would be common variable immunodeficiency, which is what Dr. Offren was referring to, where the immune system has broken through. The levels of what we call immunoglobulin G are kind of low or insufficient to protect, and there is a low level of chronic infection most of the time, and that has a true name. So in my consult in the allergy clinic, we've had patients who come to us with, I have mast cell activation syndrome, I've read that in the internet, I think that's what I have. They ended up with a diagnosis of common variable immunodeficiency. So that completely turned things around, because the chills, fever, feeling fatigue is one of the main symptoms of common variable immunodeficiency. So that systemic mastocytosis syndrome, they have that, not so on a chronic basis, but and with the whatsoever in the literature. Not even, I mean, if you try to match those two words in Google, they will never give you mastocytosis. So I'll probably the last few years. So pulling out other things and then making sure that Dr. Greenberger probably has a good cocktail for you and. Yes, of course.
The pattern you described recently with having one of your infectious episodes followed by the 10 best days you had felt in a long time, that's a pattern we not infrequently see with flares of mast cell disease. When a patient has had a major flare and the mast cells are degranulated, they're exhausted, they have nothing left to release. So without all of those, shall we say, toxic mediators flooding your system, you feel well. But during that time that you're feeling well, the cells are not inactive. They're busy recharging, so to speak. And once they have made more of their mediators and then they begin releasing them again, then you start feeling worse again. So it's a fairly common pattern. And similarly with the issue of daily cycling, that's another pattern that's been long recognized in the literature. Many patients with mast cell disorders report a particular diurnal cycle. Many report feeling worse in the morning and just slowly but steadily getting better through the day and being at their best in the evening hours, and they wind up staying up half the night because that's when they feel their best, and they don't like to lose the time of day in which they feel their best. In my experience, there's a smaller portion of patients who feel best in the morning and then worst at night, but certainly there are those patients too.
Does the serum tryptase level go up and down throughout the day? That's a question.
Very good question, and Dr. Schwartz has been looking at that. There's no a true circadian rhythm of the tryptase, but there is differences, not significant differences. With
In the morning is worse. Then tryptase would be higher. Is that right?
Well, I think that what is higher would be the cortisol level. So mast cells are sensitive to steroids. So if we put mast cells, they will not degranulate if there is sufficient amount of cortisol or steroids. So I think it follows a little bit the pattern of the steroids. When there is high steroids, there's low symptoms of mast cell degranulation. When there's low steroids, there's more symptoms of mast cell degranulation. Like you were mentioning, the prostaglandin generation, does it happen more at night? It really depends on the circadian rhythm of the cortisol. So each one has a little bit of a different rhythm. And so that can be why the pattern is different.
So tryptase, serum tryptase is normal. We cannot rule out the patient does not have mast cell disorder.
That is correct. There are two other mediators, like the histamine and the prostaglandins. An anaphylactic event. So if you
scratch the skin and then make it red, well, tryptase goes up.
Typically, the people who have limited disease to the skin, like urticaria pigmentosa, or even people who have only dermatographism, it's hard to have a raise in tryptase levels because there's little tryptase that's released. There's more histamine.
So can I just scratch my skin?
Unlikely.
this is not normal. When's the best time to catch up? Check 3 days or times or?
What we have as a criteria, the standard criteria for the mast cell activation syndrome, it says 2 times. So if the mediators, probably it has more to do with symptomatic versus non-symptomatic. So when you're fully symptomatic, it's a good time to get tryptase.
I oftentimes get just burst capillaries all of a sudden. Would that have anything to do with mast cell disease? All of a sudden I'll feel a pain in my fingers and just curious. I also wanted to know, there was some information about autoimmunity and mast cells. So somebody, say, who has the celiac gene, like myself, and I have low levels of tissue transglutaminase. So I've been gluten-free. Is there any kind of correlation with, you tend to take the things out of your diet that triggers that autoimmunity if there's any improvement in the mast cell disease?
People with celiac disease and mastocytosis, there's a minority. Celiac disease incidence in systemic mastocytosis is the same than in the normal population. Once you treat the symptoms of the celiac disease, definitely you improve all the symptoms because there is less triggers for the mast cells in the gut. So getting a gluten-free diet will definitely improve the GI symptoms of the mastocytosis disease, definitely. That's for sure. But we have not seen, the genetic association with that. Now, the capillary thing, this looks more like rhino type phenomenon. It's a vascular. It depends on the vascular bed, so it's a more autoimmune type of disease, rheumatological disease that can be associated with celiac disease also.
Very much. I'm a patient of yours. I haven't been able to see you because my insurance changed. I have systemic mastocytosis, but I'm very reactive, so I guess also MCAS too. And the interferon I'm taking has stopped my anaphylaxis, and thank you. I also wanted to ask you about ears. I'm having issues with balance, and I hear these funny sounds like that, and like if I turn a certain way, all of a sudden, and I was wondering, with hearing issues too because of the fluid buildup and what have you, because I'm hard of hearing, and also the other things, and I was wondering if that could be mast cell related too.
We don't have patients. I only remember one patient who have problems like you are telling. In this patient, we perform a biopsy of the auditive channel, and we found also lesions of mastocytosis. So, but I think
How do you do that? How do you take this test? Because I went to hearing, and they're like, you're fine. And it's like weird because, except that I lost 40% of my hearing, and I do get the fluid, and those sounds. I hear sounds like, and I'm telling you, it's like a, and
I think it's not the case because this girl I am talking about had symptoms, had episodic symptoms, as in addition to flashing or whatever, she had problems in her ears, but not constantly, because you have constant problems.
Right.
I know.
Okay,
So I think it's a different problem, and I don't have the answer of I don't know if it's related, but I don't think so. I don't know if.
Well, I think there is some evidence that having these cells in all the tissues. Certainly when there is release of mediators in patients with even allergic rhinitis, that they can actually have what we call eustachian tube dysfunction, which is that they have like water sounds in their ears, and that's due to the release of all the mediators in the ear canal, so the communication between the ear and the nose. So that eustachian tube dysfunction can occur in patients with mastocytosis, definitely.
I have mast cell activation disorder and multiple sclerosis. Now, I was interested in Dr. Thiel when he was talking about the autism and also the neurological issues with mast cell, in correlation with it. And I was wondering if there's any known markers on like the females in a family, because my grandmother had varied lists of allergies, but she's like allergic to potatoes, but then she would eat French fries. We all thought, oh, she's just a little crazy. And then my mother also had a lot of various allergies. I have a sister who's got MS.
We have to close now because they needed us out of this foyer and the program is over. But thank you very much for coming. You can finish your question with Dr. Castells, but then we do have to get out of here. Thank you all for coming. And tomorrow morning we open at 9 o'clock with the patient support groups. We have continental breakfast first.
Thank you. Thank you. Anyway, I have a daughter, or my sister has MS symptoms. I have a daughter who's had 2 episodes of optic neuritis. Another one has rashes, and then her daughter has the autism. And I was wondering, none of the males have any of this issue. And I was wondering if there's ever been any history of anything like that you're aware of, or any studies.
Well, the comment that I can make, and Dr. Mike is that there is an incidence of autoimmune disease such as lupus and rheumatoid arthritis in females. So it's a female-dominated field.
Nobody has actually ever shown that. I'm not aware also of that incidence of autoimmune disease or multiple sclerosis association with mast cell activation syndrome. It is possible that we will be able to find the same thing than with rheumatoid arthritis with lupus, and there's an association. But that's right, and it's very possible. We are just in the midst of putting numbers together.